My name is Alexis Weller. I'm with Gilchrist. Today I will be speaking about hospice versus palliative care. A lot of people confuse the two, think that they're one and the same, but today we'll go over some of the differences between hospice and palliative care. I want to thank Winter Grace Senior Ministries for allowing Gilchrist to present today for the Fall Senior Resource Fair. Today's objective will be to understand the basics of palliative care and hospice philosophies, the services, insurance coverages, and eligible diagnoses for both palliative and hospice care. It's interesting that at the beginning of life, we start off with support all around us, surrounded by loved ones. Each need is fulfilled and every comfort is provided for. But it's interesting that at the end of life, we don't share the same philosophies. Maybe that some people have the goal to be surrounded by family members. However, they may end up in the hospital and their wishes are not fulfilled. Hospice care brings everyone together. They bring teams together as well as family members to make sure that you're surrounded and that you are comfortable. The key goal within hospice is comfort and support. It's care for patients as they near the end of their life. The focus is on keeping the patient comfortable. All of the medical, all of the symptom management, it's all geared towards comfort, managing the symptoms of the disease rather than curing the disease itself. We want peaceful, pain-controlled end of life. What is hospice care? Hospice care also focuses on the family and the loved ones, providing spiritual and emotional care for the patient and family, and support for the family as they grieve after the death through bereavement services. Hospice can be provided in many places. A lot of people believe that hospice is a place. They think of the inpatient units, they think of the hospitals. Although the inpatient unit is one of the areas where hospice can be performed, it is not the only. Hospice comes to you. So in a patient's home, in nursing homes, assisted livings, independent livings, group homes, we can provide hospice care where you are at. When someone's pain is unmanageable and their symptoms are unmanageable, at that time it may be appropriate to go into an inpatient unit. The inpatient unit, you have to have uncontrolled symptoms to qualify to be placed in. So just because you're on hospice care does not mean that you are appropriate for the inpatient setting. Many insurances, charitable care, all cover hospice. So a lot of people believe that hospice is an expense that they can't afford. End-of-life care is paid for through Medicare, managed care, Medicaid. Commercial insurances have hospital benefits as well as charitable care. So if someone is underinsured or uninsured, a lot of hospice providers are not-for-profit and have charitable care to fill in those the need. What diseases do hospice patients have? There's not a one-size-fits-all. Just because you have this diagnosis doesn't mean that you're immediately appropriate for hospice. But a lot of the diagnoses that we work with are cancer, heart disease, lung disease, ALS, AIDS, Alzheimer's. However, with hospice, two providers have to certify that there's a terminal diagnosis with a prognosis of 6 months or less to live for someone to be hospice appropriate. The benefit of hospice is that you get this interdisciplinary team approach. So you have your attending physician as well as the hospice medical director. You have the registered nurse, certified hospice aide, social worker. This is a team that if you're in a nursing home or assisted living, it's an additional support on top of those nurses, those doctors, those aides. It's an additional team that focuses on hospice, that focuses on that care and support. We also provide chaplains, volunteers, bereavement counselors, and music therapists to help with the either symptom management, emotional support, to make sure that someone is very comfortable. Hospice services focus on the pain and symptom management, also offer medications related to the terminal diagnoses. A lot of people believe that hospice, when you are placed on hospice, that all of your medications are ended. That is not true. The medications really have to be supporting your diagnoses. So if you've been on a medication that you've been on for 20 plus years and you're not seeing a change, just having that medication in your routine, it's just another pill to swallow. We may relook at that to see, is it still appropriate and does it meet the goals of care for hospice? Is it really providing you with comfort? We also provide the equipment and supplies related to the terminal diagnosis, the spiritual care through social work chaplains, social work and chaplains, hospice aides, volunteers. We can provide physical, occupational, and speech therapy when needed. A lot of people believe that therapy is over. Under Medicare Part A benefits, that is the case. So if someone's on rehab in a rehab facility, they can't also be on hospice. However, if there's a patient who is in the home and the goal is to not be in bed all day, but it's not safe to transfer, we might bring in some therapists to work on safe transfers from a bed to a chair, a wheelchair, to get them out of the room, just for quality of life. Inpatient and respite stays, and bereavement counseling as well. Sorry. How do patients get referred to hospice? Often hospice referrals are started in the hospital or nursing home settings where a social worker will contact us to start a referral. However, if someone is in the home or if you have a family member or a friend, you can reach out to the Care Navigation Center. It is a great resource for those who just need information, are looking on how to start, or if this situation qualifies. We have a phone number here on the screen for friends and families in the community to call in to ask questions, to start a referral, to see if they're appropriate for hospice. Patients or family members should talk to their physician. If you are out in the community, and that hospice conversation is a good one to have with the provider of your loved one or yourself, to see what their thoughts are on the hospice benefit and to see if their social worker will start the referral. Bereavement services, once a loved one has passed on, there's one-on-one bereavement counseling offered for 13 months after someone dies. It's 24 months for a child, but 13 months for an adult. There's support groups, seminars, activities. All services are open to the community, and there's no need for the patient to have been on a Gilchrist service. So that's pretty important. If you have someone who's dealing with, if you have a family member, a loved one, someone in the community who is really struggling with the loss of a loved one, you can always refer them to our bereavement services at Gilchrist. Again, call the Care Navigation line. They're able to navigate you towards our bereavement services, but we're able to still provide these bereavement services to those who have never been on Gilchrist. Why are early referrals important? Early referrals in hospice are very important. A lot of people believe in hospice as the 24 to 48 hours when someone passes. But earlier we learned that it's 6 months, it's a 6-month prognosis. There are people that graduate off of hospice, and there are some people that have been on hospice for years. Early referrals are very important. It shifts the focus from treatment to comfort and support and symptom relief. That's important because those transfers back and forth to the hospital, those in and out of the doctor's offices really take a toll on people's bodies. It's very stressful. We're able to prevent those back and forth from the hospital because we're adding that additional interdisciplinary team approach that we were talking about before with the aides and the nurses, where we can care for the loved one in the home setting with the focus on comfort and support. It may prevent symptom and pain management problems so that the patient may live life to the fullest. Importantly, it allows our team to build a rapport with the family, with the patient, so that we know what their specific needs are and their goals of care are, so that we're meeting them where they expect us to be. Providing time for the team to teach the family and help them with the decision-making and planning. That support system for the family is very important. It's a very difficult time for people. Having the education, the support with them throughout every step of the process is very beneficial. It addresses the spiritual and psychological needs to help patients find the meaning and acceptance of end of life, as well as the anticipatory grief and loss issues. So we're addressing that before someone even passes, in addition to the bereavement process of that 13 months after. Studies have shown that patients do live longer. It's due to the individual care plans that are followed through by the interdisciplinary care team, frequent visits by the team for comfort and compliance, and usually no more debilitating visits to the hospital. So, what is palliative care? I don't mean to confuse you because a lot of people get confused by palliative versus hospice. However, hospice is palliative care, but palliative care is not hospice care. Think about that for a second. It's kind of confusing, isn't it? Palliative care works together with the primary treatment being received. That statement alone sets palliative care apart from hospice. So with palliative care, you're still focusing on keeping the patient comfortable, gearing towards the managing of symptoms and stress of the illness. That's also hospice care, right? So who can receive palliative care? Any individual with a serious illness, regardless of life expectancy or prognosis. This again sets it apart from hospice. Hospice has that 6-month end of life trajectory that's certified by 2 physicians, whereas the palliative care can be at any point in life. The palliative care approach has the same approach as hospice in that it's comfort and support. However, you're still able to receive those ongoing treatments. So who provides palliative care services? A lot of people don't know, how do I get palliative care services? A lot of people reach out towards hospice companies. A physician, a nurse practitioner, or a nurse with consultative support from social worker and chaplain services. These services are performed in collaboration, very important, with your provider to co-manage the disease process. How long can I receive palliative services? This is really dependent on insurance coverage. It's dependent on the care needs and the goals. This is not time limited per se. However, I would put the caveat on, it's really dependent on the insurance coverage. Not all insurances have a palliative carve out or a palliative benefit. If this is something that you're looking into for a loved one, reach out to your insurance company to see what are my palliative benefits. They'll be able to walk you through all of that. Most private insurances have a palliative plan. Each plan is very different, and it's often subject to a copay. Medicaid has some treatments that are not covered and may be subject to a copay as well. Medicare Part B. So Medicare Part A covers hospice in full. Medicare Part B, some treatments may not be covered, and it may be subject to a copay as well. So this palliative care is working in conjunction with your treatment, and insurance is not picking up as much as hospice care would. But there's also that difference between the additional treatment versus in hospice that's been taken away. So those are the important takeaways between the differences between hospice and palliative. The focus of palliative and hospice are pretty similar. Hospice is the pain, symptom, and stress of a serious illness during the terminal phase. The important part there is the terminal phase. That's what sets it apart from palliative. Palliative is still the pain and symptom and stress of a serious illness, but most often as an adjunct to a curative care modality. Who can receive this type of care? Palliative care, any individual with a serious illness, regardless of life's expectancy or prognosis. Hospice, however, has that 6-month trajectory. So any individual with a serious illness measured in months, not years. Hospice enrollment requires the individual to have a terminal prognosis. So very specific differences there. Can I continue to receive curative treatments? I hope by now you can answer this question. In palliative, yes. Hospice, because the goal of hospice is to provide the comfort and support through pain and symptom management with that psychosocial and spiritual support, because curative treatment modalities are no longer beneficial. Some very distinct differences for a diagnosis between palliative and hospice care would be dialysis. You can receive a palliative support through dialysis. However, you cannot receive dialysis in hospice. Typically, when someone ends dialysis, they may elect hospice because at that time, they're no longer receiving those curative treatments, but they still need that care and support. Hospice should be considered at the point where the burden of a given curative treatment modality outweighs the benefit coupled with the prognosis. Very important. Other factors to consider and discuss based on individual patient situations are treatment modalities that no longer provide a benefit due to the loss of efficacy. What services are provided? Both provide the pain and symptom management. That's where they're always going to be the same. In palliative care, it's in-person and telephonic visits. Help navigating treatment options. So you have that support system where you can discuss with them, does this go along with my goals of care? These are my goals. So does this treatment really fall in line with my goals to be comfortable? Advanced care planning, as well as referrals to community resources. So they're able to group in additional resources. Pain and symptom management for hospice, of course, but the 24-hour on-call service, that full interdisciplinary team of the hospice aide, the social worker, the chaplain, the music therapist, the 2 providers, the nurse, all to bring in that care and support system for you. In-person visits. So these are not done on the phone. Medical equipment also provides the medical equipment that you may need. If it's a hospital bed in the home or in your assisted living, we're providing that hospital bed. If it's oxygen, if it's incontinence supplies, any medical equipment that is affiliated with the terminal diagnosis, hospice company is providing. Related medications to the terminal diagnosis, inpatient care when your symptoms are unmanaged, continuous care within the home. So you're able to have a hospice service in the home, whereas in palliative, you either have to go out or do it on the telephone. Continuous care in the home, respite care, volunteer services, spiritual care, bereavement, and counseling services. Hospice also provides those services to your loved ones. Who provides the services? So we've gone over this. The hospice part is that interdisciplinary care team. That palliative team may be your physician, nurse practitioner with consultative support from a social worker and chaplain services. Ask your provider, do you provide palliative care? See what their answers are and what palliative care looks like to them. When should I refer? With hospice, patients that have received maximum therapy, so no longer receiving therapy, and the focus has shifted from symptom management and shifted to symptom management and comfort care as opposed to treat and cure. Patients with advanced chronic illness that have received maximum medical therapy and are at risk of using the hospital, so at risk of rehospitalizations, they may be appropriate for palliative care. That's a time to refer for palliative. So at Gilchrist, we provide counseling and support, elder medical care, as well as hospice care. Our counseling and support has great care and counseling, grief counseling, volunteer support, and community education programs. Our elder medical care provides nurse practitioners and physicians, as well as a social worker out in the community with the goal of supporting those who are either homebound or have difficulty getting out to the provider. They may have stopped going to the provider. We provide that nurse practitioner and that provider service in the home with the additional support of a social worker. Hospice care in the home, residential care communities, so your nursing homes, assisted livings, independent livings. Care centers are inpatient units. We have our Gilchrist Kids program, as well as care choices in hospice. Gilchrist Hospice Service Areas, Anne Arundel County, with the partnership with Luminous Health, Baltimore City, Baltimore County, Carroll County, Harford County, and Howard County. We have 3 inpatient units: Gilchrist Center Towson, Gilchrist Center Columbia, and Gilchrist Center Baltimore is our newest location with 22 beds at Stadium Place. I hope today that you were able to decipher the differences between palliative and hospice care. Very kind of intertwined. Palliative care, hospice care is palliative care, but palliative care is not hospice care. But I'm hoping that you have a takeaway with the differences and are able to now decipher. If it is still confusing to you, or if you have someone that you think could benefit from these services, please give us a call. Our care navigation team is here to help you. Thank you very much.